Thank you, Dineshan. Can you all hear me? Can you hear me?
Yes, sir, I can hear you.
Okay. Good morning, everybody. I am Nandan Jayatilaka, and Dr. Duminda Herath is also joining with me. First of all, thank you very much, GMOA, especially Dr. Anuruddha Padiniya and Chandika Pitakadua, taking a step to improve doctors' quality academically, because to improve your knowledge, improve your, as a doctor, you need to have ethically and also academically, you have to improve yourself. And also Dr. Dineshan, uh, taking all the trouble to arrange this program. Thank you, Dineshan and Manasi from the Shri and GMOA. Thank you very much for coming here in this Sunday morning. Actually, we have a plan to conduct a series of sessions like this, but as a first step today, we are going to discuss about one medical emergency and the trauma, one case of trauma, and also the blood gas analysis. So, can you hear me?
Yes.
I'm going to share. Yeah, I'm going to share my presentation.
Yes, I can hear you.
Share screen. Can you see the screen?
Yes, sir, we can see it.
Can you? Okay, yes. Okay, right. So I'm going to talk about the evaluation of the patient with syncope. First of all, syncope is one of the common presentation to the emergency department, which we have to exclude whether the patient is in risk of cardiac risk, or whether you can discharge the patient wherever you work, whether it's the emergency department or whether it's in the OPD setup or whether you are in the private sector, wherever it is. First of all, I'll go through with one case history. This is a 70-year-old patient from home, independent and referred by the GP with a past history of hypertension, hypercholesterolemia, and basal cell carcinoma. He presented with 2 episodes of syncopes for 2 days duration, and each episode lasted for a few seconds. She denies vomiting, nausea, and no chest pain, no palpitation, no features of sepsis or no sick contact of COVID, no neurological symptoms, bowel open normal, and this is the second episode was associated with the urinary incontinence. And he's on medication, losartan, atorvastatin, and allopurinol. And his family history: father has a stroke in his 60s, non-smoker and non-alcoholic, and she's from home and independent. So how do you approach this patient if this patient come to the emergency department? Yes, his airway is patent, blood breathing, respiratory rate 18, lungs clear, saturation 98, and pulse rate 78, and no radial or radiofemoral delay, and no postural drop. His GCS 15 out of 15. His pupils equally reacted to light, and size 3 is afebrile, well hydrated and not pale. There's no ankle edema and no calf swelling. So this is the initial presentation. So if these patients come to you with the 2 episodes of syncope and last one associated with the incontinence, it is your duty whether you have to treat an OPD level or in emergency department, or whether you have to identify any cardiac risk behind this. So we send the investigation, full body examination, CRP, renal function, liver functions, troponin I and ECG. So I'll take in this case, we'll discuss it. Another case, how do you approach this patient? A 12-year-old boy and out with friends for a musical show. It's a very hot day for him, and he starts to feel warm and nauseated and begins to sweat profusely. He loses consciousness and drops to the ground. There are few jerky movements of his limbs, and he's unconscious for only half a minute, but he quickly regains consciousness. So when his friends question, he tells them he's remember feeling warm and nauseated, but he doesn't remember being unconscious. When you assess him in the emergency department, he feels very fine and all the vitals are normal. So what is happening to this patient? He's perfectly normal now. Okay, we'll do the evaluation of a patient with Syncope. My objectives, we have to develop an approach to assessing a patient who present to the emergency department with Syncope and distinguish between the Syncope and the seizure. And understand the key historical and physical examination features that distinguish benign versus serious causes of syncope. Develop an approach to reading the ECG of a patient who present to the emergency department with syncope. Okay, what is syncope? Yes, the syncope. Before the talk about the syncope, we'll discuss about the transient loss of consciousness. The transient loss of consciousness is a spontaneous loss of consciousness with complete recovery. There's a temporary impairment of brain function, which is associated with the loss of awareness, loss of responsiveness, and loss of memory. So what is syncope? The syncope is the most common cause of transient loss of consciousness. So it is a subset of transient loss of consciousness. This transient loss of consciousness, patient lost the awareness and lost the responsiveness and loss of memory. But this is the transient, which lasts for about few seconds, not more than, it's not for hours or many minutes. It's just about less a few seconds or few minutes. So syncope is a symptom rather than a disease. It is caused by cerebral hypoxia and hypoperfusion. In the literature, it says that the 15% of children will experience an episode of prior to end of the adolescent. And you and me, all of the population, about 30% of the population will experience syncope in their lifetime. You also have that experience. An emergency department presentation is about 2 to 5%. Right. So what is your general approach to sudden loss of consciousness of a patient? Step 1. We have to differentiate syncope from the seizure because syncope patient can present with the movements of their hands or limbs. So people, we think that this could be a seizure, but we have to differentiate because the management of seizure and management of syncope is totally different. And then we have to categorize the syncope by underlying causes because syncope is not a disease, it is a symptom. So we need to categorize whether this is a benign or whether this is a serious life-threatening condition. It could be a autonomic or cardiac or non-cardiac. And also we have to assess the risk for future cardiovascular event or sudden death. If you do not assess properly, and if you think that this syncope in the later term we call this is just a faintishness, you can go home and enjoy, without assessing, you are putting the patient into trouble. So we have to assess the risk of future cardiovascular event of sudden death, patient who comes with a syncope. Remember, syncope is a symptoms, not a diagnosis. So if somebody asks you, what is the treatment for syncope? There's no treatment for syncope. Nobody knows the treatment for the syncope because syncope is a treatment. We have to find the cause. Syncope, it is characterized by a sudden loss of consciousness as a result of decreased cerebral blood flow with full recovery to a baseline level of awareness within seconds to minutes. It is a full baseline awareness. Recovery is full recovery. And patient comes to the baseline level of awareness within a seconds to minutes. And there are often a few jerky limb movements associated with syncope because there's a low cerebral blood flow. So which can be confused with the seizure. Right. So syncope again, syncope versus pre-syncope. This is a two-term, later, but we have to understand as doctors what is syncope and what is pre-syncope. Syncope is a transient loss of, it's a self-limited transient loss of consciousness with an inability to maintain a postural drop that is followed by spontaneous recovery without any residual effect. The pre-syncope you collapse without loss of consciousness. That is pre-syncope. So syncope and pre-syncope. Yes. What about the syncope versus seizures? That is another dilemma for us to discuss. Okay. Soft tissue injuries at multiple body sites, posturing, tonic-clonic phase, rhythmic activity are more consistent with seizure than syncope. So seizures, they get tonic-clonic phase. And any other features? Yes, they can have post-ictal drowsiness. Syncope seizure patient, they have tongue biting. Seizure patient, they have urinary incontinence. But both syncope and seizure can cause urinary incontinence. But unlike seizure, patient with syncope return quickly to their baseline level of alertness. Then what about the pseudo seizure? Have you noted the pseudo seizures? Sometimes the teenagers coming with pseudo seizures, they try to mimic that they are having a fit, they are having a seizure. But what are the important factors for you to understand whether it's a pseudo seizure or syncope? You know how to differentiate syncope versus seizure. But patient with pseudo seizures, they present with incontinence, they can urinate, they can come with the tongue biting because they can bite their tongue. When you analyze the pseudo seizures, most of the time pseudo seizures occur in the presence of others because he or she need to draw attention from the others. And usually they don't harm themselves, especially their faces. They protect their face. And the other important thing, mind you, in pseudo seizures, the seizures, one of the pathognomic clinical feature is the lateral tongue biting. You can bite your tongue, the tip of the tongue, but you can't bite your lateral part of your tongue. Try and see whether you can bite your lateral part of your tongue. You can't. So lateral tongue biting is one of the pathognomic feature of seizure, but in all the cases you don't see. So you have to, you know now what is syncope, what is pre-syncope, what is seizure, what is pseudo seizure. Right. What are the causes of syncope? Yes, cardiac syncope and neural mediated or reflex syncope, then apneic syncope, and that is because of the patient with apnea. When we take a deep breath, you get the syncope because of the poor cerebral blood flow. Vascular syncope, reducing the vascular tone, and cerebral syncope, G-force induced loss of consciousness, that is the gravitational force induced loss of consciousness. And mixed mechanism, we can having all these, especially neural mediated reflex syncope and the cardiac syncope together, and also orthostatic intolerance, where when you're standing for a long period of time, you get the syncope. Okay, we'll go with the cardiac syncope. The cardiac syncope is caused by an abrupt drop in cardiac output, which is caused by an arrhythmia, typically tachyarrhythmia. For example, like long QT syndrome, the Brugada syndrome, pre-excitation syndrome. So there are cardiac factors, so especially typically the cardiac arrhythmia, tachyarrhythmia, and also structural heart disease, patient with hypertrophic obstructive cardiomyopathy and severe aortic stenosis. Aortic stenosis patients come to you when he's trying to exaggerate his exertion, like when usually they come when he was trying to catch a bus, he was just quickly wanted to run, and then suddenly he developed a seizure. That is because of the poor cardiac output due to the severe aortic stenosis. And acute myocardial infarction can come with syncope and cardiac failure. Then other one is neurally mediated or reflex syncope. So there is an abnormality of autonomically mediated alteration is vasomotor tone and the heart rate. So we need to have a vasomotor tone and heart rate to maintain our blood pressure and cerebral perfusion. But with a patient with neurally mediated or reflex syncope, there's a cardio inhibition, the sudden bradycardia and carotid sinus hypersensitivity. So with that, there's a vasodepression, which is inappropriate peripheral vasodilatation and reducing the vascular resistance and systemic blood pressure. So these type of patients, they develop the syncope because of poor cerebral perfusion. They can't maintain their adequate cardiac output due to bradycardia, sudden bradycardia, and sudden vasodepression or vasodilatation. Are you okay up to now? I want to hear some of you. Can you hear me or
Yes, sir. Yes, sir.
confusing you?
Yes,
No,
sir.
sir. It's
And
clear.
what?
Can hear, it's clear. Clear, sir.
Okay. Can you understand? If you have any question, let me know. You can disturb me at
Can you
any point.
exit the presenter view, please?
Sorry. Okay. So if not so, we can have the neural mediated syncope, or we can have the mixture of the above. That is, by far the most common type of syncope is the typically associated with the presyncopal symptom. It's widely known as vasovagal syncope. What we call vasovagal syncope is the neurally mediated syncope or reflex syncope. But this neurally mediated syncope is generally thought of an benign condition. But if severe or frequent presentation with the same syncope, yes, it causes the marked morbidity and disability. So we need to admit the patient and we have to find out general what is the cause behind this. Then we'll talk of apneic syncope, which you might have also experienced. So this is the apneic syncope include upper airway obstruction or valsalva related syncope and with the hello. So because of this, when there's a valsalva maneuver, there's a reduced venous return as the chest is held in expiration. So when the increased intrathoracic pressure, there's low cardiac output, which low venous return, and which reduces the cardiac output, which impairs the cerebral perfusion. And then the vascular syncope. So this is caused by reduced circulating blood volume leading to reduced cardiac output and hence impairment of cerebral perfusion. So vascular syncope is due to hypovolemic shock, septic shock, anaphylaxis, systemic hypotension, and obstructive shock like pulmonary embolism. So far, can you see the patient who comes with syncope? We have to consider many things, whether it's a vascular, neural mediated, or reflex syncope, and especially the vascular syncope, you have to think about whether the patient is in anaphylaxis or whether it's a systemic hypotension or hypovolemic shock. It's a young girl coming with the features of syncope, probably with the hypovolemia or hypertension due to the ruptured ectopic pregnancy, which you have to identify. Then what about the cerebral syncope? So this is the obstruction to the cerebral blood flow can occur acutely in due to adolescent stretch reflexes or transient ischemic attack, or it could be a CVA. What is this G-force induced loss of consciousness? This is unusual type of syncope which occurs from excessive and sustained G-forces, which usually comes with generally in the astronaut and pilots, which you and me don't experience this. Okay, we'll move to the mixed mechanism. Some cases, multiple factors contribute to the syncope, like low partial pressure of inspired oxygen, anemia, the dehydration, the vasodilatation and exhaustion will make the syncope even more likely. So this is the mixed mechanism, like anemic patient coming with dehydration and coming with hypovolemia. This could be a mixed mechanism for syncope. Orthostatic intolerance. So this is closely related to the neurally mediated syncope or reflex syncope. This orthostatic intolerance, the patient experience pre-syncope or syncope. Other symptoms ongoing from the recumbent to the upright normal neutral position. Because when you upright from the normal recumbent position, there's a cardiac reflex to increase the cardiac output and increase the stroke volume by increasing the heart rate. to perfuse cerebral, to maintain the proper cerebral perfusion and increases the vascular tone. But in orthostatic intolerance, patient with orthostatic intolerance, because they manifest orthostatic hypertension with or without depression or neurally mediated syncope or postural tachycardia, because they can't maintain the vascular tone properly. So they can't increase their heart rate. So this is the orthostatic intolerance. This can be diagnosed with drop of systolic blood pressure of at least 20 mercury millimeter or drop of diastolic of more than 10 mercury millimeter ongoing from supine to upright position. This is orthostatic intolerance. Okay, so this is some medical causes. What about the medication? What about the drugs which can cause the syncope? Are you okay so far? Can you all hear me?
Yes.
Yes, sir.
Yeah, okay, good.
Yes, yeah, okay.
Right. What are the medication which commonly implicated in syncope? Erectile dysfunction drugs, antihypertensives, beta blockers, cardiac glycosides, diuretics, antiarrhythmics, antipsychotics, because it causes a lot of sedation, antiparkinson drugs, antidepressants, and phenothiazine, nitrates, alcohol, cocaine. So there are a lot of medication drugs which causes syncope. So when you come across a patient, we have to take the proper history and proper past history as well as the medication he is on. There are a variety of conditions that mimic total loss of consciousness. These include, we have to keep this one in mind, we can come with the total loss of consciousness, especially neurologically, seizure, as I discussed with you earlier, subarachnoid hemorrhage, and vertebrobasal insufficiency, and increased intracranial pressure. And also there's a metabolic causes. Probably the hypoglycemia can come in as a syncope, which you have to find. If you miss it, you miss the patient. And the hypokalemic periodic paralysis and alcoholic patient come with the syncope because of alcohol patient with the dehydration, they can come. So we have to get the proper history from the patient. Why this patient has got this syncope at this moment. If you miss it, I mean, you discharge the patient thinking that this patient is normal, you can go home. But if you don't identify these metabolic disturbances, you miss the patient. And also functional, which is a dissociative state, and conversion disorder and somatization disorder, this also come as a syncope. How is syncope evaluated? How do we evaluate the syncope? First thing, a detailed history and physical examination will identify the cause of syncope in nearly 50% of the patient. Nearly 50% of the cases, you can identify the cause for the syncope. So you need to get the history and physical examination, proper history and physical. And a 12-lead ECG should be obtained in each and every patient who come to the emergency department, or where in your private sector or OPD, wherever you like, you have to get the 12-lead ECG. Routine labs and neuroimaging are not always recommended, not always necessary if your history and examination is proper. And if you usually simple syncope, you don't need to go for the neuroimaging, but you have to exclude all the rest of the things. And you have to determine appropriate setting for this patient. That is, whether the patient is inpatient or outpatient department. And you have to identify those where no diagnosis has been found. So patients come with syncope, which you can't find the cause. Those patients these patients need further workup. Detailed workup is the patient if you can't find the cause for this syncope. Okay, we'll talk the historical features, what you should look for. The pattern. The pattern, this is the first presentation, or is there a pattern of recurrent episode? So if this is the first presentation, or if this patient's coming with recurrent episodes of syncope, or position, what position the patient was in while he's getting the syncope? So whether the patient was physically exertion is involved during this syncope, or what was happening at the time before syncope, whether there are prodromal symptoms before syncope. If a patient comes with a syncope out of the blue, that is an alarming sign. And the signs and symptoms, so whether the patient with a diaphoretic or dry or flush or cyanotic, hello, whether he has the chest pain, palpitation, and was that the patient is experienced was the notice like any other person, whether she was complaining of chest pain or whether she got the seizure activity. And the other thing, onset is important. How acute was the onset? That is whether it's preceded by prodrome or all of a sudden the patient developed the syncope. And the movements, where there are involuntary movements involved, like jaw locking, tongue biting, and when the movements start before or after the onset of syncope. And then the color of the patient, whether the patient is pallor or the flushed or whether he was cyanotic. And the other thing, how long did the unconscious last? Usually syncope, it lasts for seconds or minutes. And recovery, whether there's a confusion or no confusion after syncope, or the patient is returned to the normal baseline. An injury, did the patient sustain any injury like tongue biting, I told you earlier, and whether any trauma? What are the high risk category for the seizure, syncope? There are high risk categories like syncope during physical exertion is a high risk patient. So we need to investigate thoroughly. And family history of sudden cardiac death, which is so important. If the patient coming with syncope associated with a chest pain is a high risk patient. The patient with past history of structural heart disease coming with syncope, yes, is high risk patient. And abnormal cardiac examination, if you find something in cardiac examination like irregular pulse or radial delay, the patient is having a murmur, or whether there's a focal neurological findings, and whether the patient's having a recurrent episode of syncope. If a patient's coming with recurrent episode of syncope, though it is a simple syncope, but if it's coming in the recurrent episode, that has to be investigated. And child coming with syncope less than 6 years, which this patient, you can't just send him or him home, because this patient has to be evaluated very well. Okay, what are the objective scores which we use to assess the syncope? This is called Canadian syncope risk score. They assess the patient whether the predisposition to vasovagal symptoms, whether the patient has a history of heart disease, any systolic blood pressure less than 90 or more than 180, elevated troponin, and with all these patient give us the score whether your patient is in high risk or whether your patient is in low risk. If the patient is in medium or high or very high risk, yes, you have to admit the patient for further workup. And then, this is another score we use in our emergency department. Whether the patient has got features of heart failure or features of history of congestive heart failure, or hematocrit less than 30%. And whether there's any EKG abnormalities, any non-sinus rhythm, yes. Shortness of breath during the syncope, or the systolic blood pressure less than 90. So these sort of patients categorized as a high risk patient. So for that we have a mnemonic. The chest is the mnemonic, congestive cardiac failure, hematocrit less than 30%, and EKG changes, systolic blood pressure less than 90%, and shortness of breath. These all are, we have to evaluate whether this patient, your patient has these symptoms. Then this patient belongs to high risk patient. What are the cautions? Any patient with abrupt syncope with little or an absence of prodrome must undergo a more extensive evaluation because of an increased risk of serious cardiac disease and the future sudden cardiac death. If a patient comes without any prodrome symptoms with abrupt onset of syncope, that patient has to be evaluated thoroughly. So what is the clinical pearl? The syncope with cardiac etiology typically include at least one of the following features which warrants a further workup, like exertion with syncope, chest pain and palpitation and dyspnea associated with syncope, abnormal physical examination like irregular rhythm, pathological murmur, abnormal heart sound like third heart sound, abnormal ECG, and family history of sudden cardiac death before age 50. So these patients need further workup. So clinical for the syncope with exertion or preceded by palpitation or absence of prodrome. If you have a 2 out of 3, 100% sensitivity and specificity for cardiac origin. Syncope with exertion preceded by palpitation or absence of prodrome. If you have a 2 out of 3, this is 100% sensitive and specific for cardiac origin. These patients you need to have a workup. Examination of the patient with syncope. What examination you should look for? Yes, appearance like external injuries like pallor, features suggest of child abuse. That has to consider if a mother bring a patient that is always having fainting attack or having a syncopal episode or collapse. Please think about non-cardiac or non-accidental injury or child abuse. And cardiovascular system, pulse important, rate, rhythm, pulse deficit or delay, and blood pressure. Whether there's a blood pressure difference on right and left, and the oxygen saturation, auscultate your heart and identify any murmurs, and any abnormal findings in the cardiovascular system require deep cardiac evaluation. And perform neurological examination, cranial nerve examination, deep tendon reflexes, gait and coordination testing has to be done. Other system of history suggests like abdominal examination in adolescent girl to exclude ectopic and intra-abdominal bleeding, rectal and perineal examination to exclude any child abuse. These are very important things when you see a patient with syncope. You think that the syncope, the patient with child abuse, they don't come with the syncope. But if you have a patient, a child with recurrent episode of syncope, you have to look these things, because if you miss it, you miss the patient, you miss the diagnosis. What are the laboratory evaluation? ECG is the single most important test in evaluating patient after a syncopal episode. ECG, and ECG. ECG interpretation in patient who present with syncope is all about ECG intervals. You don't need to know ECG like cardiologists. I'm not a cardiologist, but you don't need to know a lot of things in ECG. Just a simple thing. We'll see what are these simple things. Just the intervals only. First, PR interval. The short, if your patient coming to you with a syncope, you see the patient's PR interval is short. Could be WPW syndrome. Or long PR interval could be cardiac block, and QRS interval narrow and deep QRS you see in the hypertrophic obstructive cardiomyopathy, or the wide QRS complex with ventricular tachycardia, and then the wide QRS complex with epsilon wave, we got the arrhythmogenic right ventricular hypertrophy. So what, and the QT interval, the long QT interval we call and also short QT interval. So you don't need to diagnose with this ECG. Please remember that you don't need to diagnose. To take the ECG and see whether these intervals are good. PR interval, QRS interval, Q2 interval. As a basic doctor, you know what are the numbers of these intervals, and check whether you have these abnormalities. If you have these abnormalities with patient is syncope, yes, of course, this patient needs further evaluation. See, this is normal EKG on your left side, and right side you get the long QT interval, and this is normal ECG. Just to make sure, can I ask a question from the audience? What is the difference between interval and the segment of ECG? What is the segment? What is the interval? Can somebody answer? There are segments,
Yeah,
there are intervals. Yes.
Yes. No, segment is the particular wave. And the interval is from one wave to the other wave, the time frame.
Yes, good. The interval includes, for an example, ST segment. First is QT interval, which includes the T wave, and which include the Q wave, either Q wave or T wave, which should include in the interval. But if you take the segment, like say ST segment, which doesn't include either S segment or T S wave or T wave, so that is segment. Other confusion. If you talk about the PR interval, at the start of the P wave and the start of the R wave is a PR interval. And what is the PR segment? So that is end of the P wave and start of the Q wave, R wave. That is PR segment. So that is the difference between the segment and the interval. So in syncopation, we have to deal with the intervals. Segment also important like ST segment. But if you don't have ST segment, check whether the intervals are okay. So that is the difference between segment and interval. Right. So what is this? So this ECG findings of a patient with hypertrophic cardiomyopathy, which include increased QRS complex voltage is like a dragger-like Q waves, and ST segment in T wave sign of left ventricular hypertrophy. You see the Q waves in lead 2, 3, AVF, and V5, V6 in the ECG. So if you see this sort of patient, and you don't need to go for the diagnosis, you see some abnormalities of this patient with coming with syncope. You see that the patient has abnormal Q wave and ST segment and T wave findings. T waves are features of left ventricular hypertrophy. They are abnormal Q wave. So I think this is, though you can't diagnose this patient, please admit the patient, inform the cardiologist, because this patient needs further workup. Right. What is this? And this is a bit of a difficult one. This is I told you about the epsilon wave, the patient with the broad QRS complex and following by the epsilon wave. This is the patient coming with arrhythmogenic right ventricular contraction. So there's inverted T waves in right precordial lead and epsilon waves. You can see the epsilon wave with the red arrow, and which is a low amplitude notch after the QRS. And see these subtle changes whether you can see in your patient. Right. What is this patient? Can anybody tell?
WPW.
WPW syndrome, because the patient is having a delta wave here. There's some abnormality. You don't need to diagnose, but there is some abnormality. This patient coming with syncope. Yes, you need to admit and you have to do the further workup. WPW. It's a short PR interval and less than 3 small square and slurred upstroke to QRS indicating the pre-excitation and the delta wave, broad QRA. And so this is the WPW syndrome. So this patient, can somebody explain about this patient, something which you can see, any abnormalities of this patient? Any abnormalities? Okay, so this patient has left bundle branch block. Ectopic left bundle branch block is there with this patient with prolonged PR. PR is 206 and there's a left bundle branch block. So this patient need admission for further workup. This is a bifascicular block. Right. So clinical pearl. While a QT, corrected QT interval, which is more than 500, what is the normal QT interval? It's 460 in male and 420 in female. So if the QT interval is more than 500, it's considered as high risk for torsades de points and sudden cardiac death. In a children of QTC interval more than 450 is considered high risk, warranting referral to cardiac electrophysiology. So if you have a patient with QT interval is more than 500, that is high risk. You have to admit. So you have to calculate the patient with QTC. And the short QT syndrome, if the QTs is less than 340, in patient with or 316 patient with family history with sudden cardiac death, this patient need further investigation. So if you have a patient with QT interval more than 480, or if it is less than 340, which all should need further investigation. So this is the Tosardi points. This patient has the long QT syndrome, and then following the Tosardi points. Right. What is Brugada syndrome? This is some theoretical thing. Brugada syndrome, you can see the young patient come with the Brugada syndrome. This patient, young patient coming with syncope, you have to exclude this Brugada syndrome. This is the type 1 Brugada syndrome, where the curved ST segment with elevation more than 2 millimeter in V1 to V3, and with the followed by a negative T wave. This is the typical Brugada pattern Brugada syndrome. This is the only ECG abnormality that is potentially diagnosed with Brugada syndrome. This patient coming to you with the ECG, this patient definitely need further admission, further workup. This is the Brugada syndrome. There are many types, type 1 and type 2. This patient had the saddleback type ST elevation and more than 2 millimeter ST elevation. This is another type of Brugada syndrome. But you don't need to know all these big terms, but if you can identify something wrong with this ECG, that is important, that is enough for you, because you are not going to treat as a cardiologist, that is the field of cardiologist, but you are not going to treat this patient. What you have to do is you have to identify without any mistake this sort of patient. And this is the type 3. This is the morphologically either type 1 or type 3, but with less than 2 millimeter ST segment elevation. So this is the Brugada type, which you can Google and see Brugada type 1, 2, and 3. So what is the other one is the commotio cordis. Have you heard about the commotio cordis? This is the commotio cordis, is a life-threatening dysarrhythmia causing cardiac arrest. Some patient come with the is often be confused with syncope. The patients with typical presentation is while they were playing at playground, patient coming with the syncopal episode, or they have the unconsciousness. So this is really unconscious, not the syncope. This really unconscious coming because this is most commonly occur in sporting event. But the not only in the sporting report, some cases have identified with the result of abuse and fighting. This patient, what the pathophysiology is, the ventricular fibrillation is the most common dysarrhythmia, and heart block, ventricular tachycardia, and asystole also can occur. What is this commotio cordis? Sometimes, the patient who is playing rugby or some fighting, they suddenly had a cardiac arrest, suddenly they were arrest in the ground. This possibility of commotio cordis. This is something like this. The cause is direct non-penetrating low impact blow to the chest directly over the heart at the critical time during the heart cycle. So if you get the patient's heart cycle in this position, and if you get the low impact blow to the chest, patient will develop ventricular fibrillation, arrhythmia, and asystole. This is commotio cordis. This is one of the picture taken from the internet. So if you get the anterior chest wall, you get the blow over there during that particular cardiac cycle. This induce arrhythmia. So this is called commotio cordis. This most of the say this patient got by the ball, and at this particular, can you see this one? This particular interval, and you get the patient with arrhythmia. So this is a commotio cordis. Right. What are other investigation you need? Like ambulatory ECG monitoring, exercise testing, full blood count, electrolyte, blood glucose, thyroid function, and ictal video encephalopathy if you suspect EEG, but that's not, not doing in the emergency department. We'll refer to the proper neurologist or the further workup. And other investigation, neuroimaging is only very rarely appropriate if this patient is syncope. And if the signs and symptoms are suggestive of increased intracranial pressure or hydrocephalic attack, then you can go for the imaging. Other thing, head up tilt test, which is done in the cardiology unit to check whether the patient is having orthostatic or neurally mediated reflex syncope. Right. One treatment I will discuss, the treatment of vasodepressor or mixed neurological vasodepressor and mixed neurally mediated syncope. This patient, they come with the, most of the time the school boys and girls, they come with this sort of features. Advise the patient to drink more water to make the urine colorless during the day and the first morning in the urine until they colorless. You have to take a lot of water because this sometimes with the feature of dehydration. And also additional oral sodium supplementations are generally, I mean, it's easier. You can advise them to take once you investigated the patient, if patient is having a neurally mediated reflex syncope, or sometimes we had to get some manuals for them to do while they were having a long standing standing for a long period of time. We have to advise them to take enough water, otherwise they have the syncope and they can injure themselves. Right. Next thing, so that is all about syncope. So if somebody asks you what is the medication, what is the treatment for syncope, can you give an answer?
No treatment for syncope. That's a symptom.
Yeah, it's a symptom. What we are doing, we are analyzing a symptom here. We are analyzing the future cardiac risk. We are analyzing whether the patient can be discharged or whether the patient needs further work. But syncope is a very common presentation to the OPD or your private sector or emergency department is a very common presentation. The summary. Syncope is the most common cause of total loss of consciousness. Neurally mediated syncope is the most common cause. And syncope is often poorly understood but can be very amenable to treatment. A careful history and physical examination is often all that you require to make the diagnosis. But some ancillary investigation are frequently indicated, like 12-lead ECG in all children and with total loss of consciousness, and blood test in selected cases, only with the selected cases. Ambulatory ECG monitoring, exercise testing, and head up tilt testing, blood pressure checkup, and heart rate and video EEG are some of the investigation patient need. Proper approach, which frequently leads to a significant reduction in morbidity and improvement in the quality of life. Some patient, a lot of patient complaining all the time, they have some syncope for drop attacks, but nobody has. Sometimes if you don't evaluate properly, you will miss the patient. You come across the patient with cardiac arrest or asystole.
Good morning, everyone. Hope you can hear me. Again, thank you very much, GMOA, for initiating this continuous medical education program for doctors, which is a timely needed intervention, as most of us need to be updated on our topics to manage patients day-to-day basis. Right. So the next we will be talking. I will be talking about general approach to a multi-trauma victim in emergency department. So I'll be emphasizing on general aspects. I'm not going to detail on specific the specialty things, but I will be dealing with some of the basic approach things which will be needed for us to manage a critically ill multi-trauma victim in emergency departments. Right. So why do we need, I will get, so we need to know why the trauma is important in our country. Of course, over 1 million hospital admissions and over 1,800 deaths in 2017 in Sri Lanka. That means like about 6 or 7 deaths per day due to trauma. And all over the world, in 2013, 5.8 million deaths. Out of that, 1 million deaths are due to road traffic accidents. So it's a burden to most of the countries, and especially the working population is lost or debilitated due to the trauma. So that's why we need to know how to deal a trauma victim, because saving life, saving complications will be important for a country, because you will lose the productive life if you don't treat them well. So these are the figures which says the mortality due to road traffic accidents. If you see this, it clearly says depicted that the mortality rate will be high. The mortality rate will is high in countries where there is developing countries where there is poor healthcare system. So which is important aspect in our country as well. So we need to have a good trauma care systems, and thereby we can reduce the mortality and morbidity in trauma victims. Right. If we don't talk about the history, little bit of history, it will be not nice, because the advanced trauma life support, which is launched in United States in late 1970s, after a tragic accident to an orthopedic surgeon and his family, where his wife and his wife was dead, and the 3 children were critically injured. And he has seen the horrific way of treatment to his family members, so which lead to development of advanced trauma life support course in late 1970s in United States. Give me a second. So after 1970s, there's drastic changes in medical retrieval and aeromedical retrieval in United States, Europe, and Australia, where it has shown there's marked improvement in trauma care. So this is why we need to talk about the trauma deaths and the trimodal distribution of death. So I think most of us have seen this, where within first few minutes, there's 50% of trauma deaths occur. That's mainly due to major brain injuries or major great vessel injuries, and other 50%, or out of that, 30% due to 30% occurs within minutes to hours, mainly due to blood loss and airway problems, and the rest of the 20% happens as late complications of trauma due to bleeding and also due to any infections. So first 50% we might not be able to help, but the rest of the 50%, effective trauma care systems can reduce the mortality. So I will introduce few terms. One is golden hour in trauma. So that is not a strictly defined time period or the first hour, but early and prompt treatment will reduce the mortality and morbidity. So whenever possible, treat major trauma patients earlier as possible. So when it goes to the pre-hospital care, we are talking about the platinum minutes. We talk about the platinum 10 minutes, that is first 10 minutes after arrival of the emergency medical services to the scene. So once the emergency medical teams arrives, so they can start treatment. So that is where we talk about the platinum 10 minutes. So there are various ways the emergency medical teams will react to the trauma. Some, of course, with the resources, some teams might do some resuscitation, and sometimes some teams, of course, do the scooping and running. Right, and in Sri Lanka, of course, with 1990 introduction, and there are emergency physicians who are interested in doing retrieval care services. I think in Sri Lanka in future years, we'll be able to run a good pre-hospital care services in our country as well. So the process include it starts in pre-hospital care in the field, and then once the patient receives to the hospital, the patient will be like assessed primarily, and then rapid resuscitation will be done, and then followed by the going through a secondary assessment, and then go for the radiology and for the definitive treatment and disposition. So this is the process where the patient will undergo following a trauma. So to have a proper trauma system, the patient will go each and every step without any problems smoothly, thereby we will have a good outcome. And one other very important aspect in treating trauma victims is should not get distracted with all these ugly injuries, because as in this picture, the patient might have a very badly injured lower limbs, but the cause of death, the probable cause of death may not be this. The patient might die of airway problems, patient might die of tension pneumothorax. So we have to make sure that we stick to the basic protocols in ATLS to reduce the mortality and morbidity of a trauma victim. So the concepts are, as everyone know, we have to approach systematically, that is the ABCDE approach. And also other important thing is you have to work as a team. So as an individual, you can do few things, but it should be coordinated and should work as a team. So haphazard things can damage the process of ATLS. And also to start treatment, you should not wait until you diagnose this. So once you assess, you have to treat. And most of the time, a detailed history is not available on a trauma victim or the critically ill trauma victim. So you should not delay the treatment saying you don't have the history or you don't have a proper diagnosis. So that is most important in managing a critically ill trauma victim. So as I said, the process starts at pre-hospital care or retrieval services, where the care services is transfer of critically ill trauma victim using a specialized staff with the transport platforms and with equipments. That is done by the emergency medical services. In the Western countries, certain instances where the doctors are also involved in aeromedical retrieval. The retrieval can happen either aeromedical or by road. And there are, as I said earlier, strategies used. Like, some people, of course, use scoop and run strategy, and some, if they have facilities, expertise, they might stay and play. So once a patient is retrieved from a field, the patient will reach to the hospital. So in hospital, we have to have some basic facilities to make sure the patient will have a good outcome. So, so we have to prepare ourselves to tackle the patient, and the patient might undergo a triaging. So once the patient is triaged, the patient will be assessed primarily and then resuscitation. And we might need to know things about adjuncts to primary survey, which will give important aspects for our diagnosis. Once the patient is stable, and after primary survey, the patient will undergo a secondary survey where the patient will be assessed head to toe. And once the patient is assessed, the patient might, so some patients, of course, once the primary survey is completed, and if the patient is stable, patient might go to a theater. But some people, if the patient is stable after the primary survey, they will undergo the secondary survey, and then they will go for radiology, and lately they will go for definitive care. So this is the process in a hospital with multi-trauma victim. So for the preparation, there are like, if you need to prepare for trauma, so you need to prepare ourselves as human resources. We need to conduct educational programs, skills improvement, and also we might need some of the machineries, some of the monitors. So we need human resources and equipments as well. So this is a place where a major trauma victim is resuscitated. We call it like resuscitation base in hospital, where it's like a intensive care unit with a basic surgical equipments are there, because the patient might need a finger thoracostomy, sometimes emergency department thoracotomy. So this should have monitoring, basic surgical care, and the ultrasonography, everything should be included in a hospital resuscitation there to treat a multi-trauma victim. And there are some other terms, a trauma call, where the trauma call is given by the emergency medical services from a field, where there are criteria to activate a trauma call. It's mainly due to the parameters and also the mechanism of injuries will activate the trauma call by a emergency medical services. So in Western countries, where if the trauma call is activated, most of the time these patients are will be bypassed. The small hospitals will be bypassed. Like, they will go to a referral center or trauma center, bypassing small hospitals where they don't have enough surgical specialties. So that is important to treat a patient without a delay. And because the call is given, the patient or the hospital is prepared to accept a trauma victim, thereby the delay is minimized. So in hospital, you will have a trauma team. So as a trauma team, it's a multidisciplinary team which has emergency physicians, anesthetists, general surgical registrars or general surgical team, and also depending on the indication, they will have a specialized surgical teams available. And also some, of course, if you have the radiology facilities, sometimes CT facilities, that team or that team also will be included in a trauma team. Right, so once the patient receives to the hospital, patient will be triaged according to the vital signs, and he will be placed on a resuscitation bay for further care. So as everyone know, the primary survey includes ABCG, E, and airway with cervical spine protection, that is the first step, and the breathing and ventilation, a circulation with hemorrhagic control. But if there's exsanguinous bleeding, so the hemorrhagic control sometimes can come up in the list. So once you are done circulation, so you need to have a brief neurological examination. And finally, so you need to expose the patient with environmental control. So as a team is involved, so in practical way, so most of these things can happen simultaneously, because airway doctor might be taking care of the airway, and the procedure doctors or the other ones might do the B and C simultaneously or D simultaneously. So the most important thing is in ABCD approach, if you see any signs of instability in this patient, make sure you reassess these patients. So you need to reassess patients in subsequent quick times. where if you see any instability in any of the condition, any of the A, B, C, D, E, you need to reassess this patient and adjust whatever you need to be corrected. So our ultimate goal in treating or resuscitating a trauma victim is to avoid hypothermia, acidosis, and coagulopathy. Those are the lethal triad of a trauma. So when you are resuscitating, make sure we don't make sure we prevent these three happening. So our aim is to correct all these three to make the patient make him a survivor. So airway. So how do we evaluate airway? The most of the airways in trauma victims are not tested. So we take all the airways as a difficult airway in emergency department. So make sure when you are preparing for airway equipment, you prepare with a difficult airway kits. So you need to have a difficult airway trolley, prepare for the worst. And so you need to have plans, rescue plans. Once if a plan fail, you need to have a rescue plans. So the simple way, how do we know the airways pattern? Like if the patient is able to communicate verbally, you have a good idea that the patient's airway seems to be fine at that time. And what are the signs of threatened airway? So you need to see whether the patient is having a stridor, hoarseness, or any secretions or blood and some other foreign bodies visible in his airway. So it's a sign of airway threatening. And all the patients coming with multi-system trauma, you have to suspect that the cervical spine is damaged unless proven otherwise. So you need to clear the cervical spine, both clinical aspects and it also from the radiological aspects as well. So whenever you need to do some intervention in uncleared cervical spine, you need to do it with manual stabilization. So when you are transferring a patient with suspected cervical spine injury, you need to stabilize it with headlock, head straps, and body straps as well with the cervical collar. Right. So so when you see any threatened airway, there are some maneuvers you can do. Jaw thrust is the one we use. We don't do the chin lifting maneuver. And depending on the situation, sometimes you might need oral or nasal airways, but be careful if there's any evidence of basal skull fractures, we don't go ahead with nasal airways. And also, if the patient cannot maintain the airway, we might need definitive airway with earlier we call it rapid sequence, now we call it like drug assisted intubation with cervical spine control. And when you are intubating, there are concerns over the cricoid pressure and external laryngeal manipulation. Some of course use these things, and there are doubts in whether it is practiced or not, but depending on the expertise level, some people of course practice these things in their facilities. So for the intubation, video and optic imaging techniques are preferred, and also the tube placement should be confirmed with a entitled carbon dioxide level. As I said earlier, we should have rescue plans if one plan is failed. And needle cricothyroidotomy and surgical cricothyroidotomy will be a final option if intubation fails. Right, so the spinal motion restrictions or manual inline stabilization can do for any interventions when you are doing in a suspected cervical spine injury. So when it goes to the BRE, So we had to do the basic things as inspection, palpation, percussion, and auscultation. And you had to look for signs of deviated trachea, crepitus, failed segments, and sucking chest wounds. So there are 6 life-threatening chest injuries. There are some other chest, there are a lot of chest injuries, but there are 6 life-threatening chest injuries where we might have to pick up in our primary survey. So one is tension pneumothorax and the open pneumothorax or the sucking chest wound, and massive hemothorax. That is, so once you put the IC tube, if you have more than 1.5 blood stat coming or more than 200 milliliters over 2 to 4 hours, and some of the airway disruptions, cardiac tamponade, and failed segments are life-threatening problems when you have to detect during your B assessment. So cardiac tamponade will be difficult in a busy ED setup to diagnose clinically, but as everyone say, Bextrad or can use. So you might see the clinical signs of Bextrad, but the cardiac tamponade will be identified using point of care ultrasound. Right. So this is a picture of a tension pneumothorax where you will see deviated trachea with collapsed lung. So this need decompression, where if you have facilities, you don't need to go with the needle decompressions. So in emergency department, what we do is, like, if you see a tension pneumothorax, we do the finger thoracostomy in a safe triangle, mid-axillary line in 4th or 5th intercostal space. But in a periphery, if you do not have facilities, you go along with the needle decompression, again in the same place, in the safe triangle, mid-axillary line, 4th or 5th intercostal space. And if you are inserting a chest tube following that, you can insert a chest tube with the gauge of 28 to 32. People, of course, use the they are saying that if it is a purely pneumothorax, they will prefer for a small tube, and if you are suspecting hemothorax, they will go for a bigger one. And if you find a sucking chest wound in periphery on your field, you can have occlusive dressing, 3-sided occluded and one side is open, to prevent air sucked in. And once the patient is coming to the hospital, you should never put IC tubes in a sucking chest wound. IC tube should be placed with the normal on the mid safe triangle in a mid axillary line, and the sucking chest wound should be explored and closed carefully. Right. So as I said earlier, the point of care ultrasound has placed to identification of the pneumothorax and cardiac tamponade as well. So this is a picture of a chest tube placement in a trauma victim. So when it goes to the circulation, so all the trauma victim, if a trauma victim comes with a shock, we have to suspect hemorrhagic shock unless proven otherwise. There may be a bit, the patient may have had like other shocks, like tension pneumothorax causing obstructive shock or some neurogenic shock, but make sure you don't miss hemorrhagic shock in a major trauma victim. So you have to assess the hemodynamic status using pulse rate and blood pressure, pulse and blood pressure, and capillary refilling time with consciousness. So this is very important slide in our clinical practice. These are the classes of hemorrhagic shock. So you take heart rate, blood pressure, pulse pulse pressures and urine output and consciousness to assess this. So there are 4 classes, class 1 to class 4. Class 1 says like it's less than 15% and there are no clinical signs. Starting from the class 2, there's a tachycardia. So if a patient is coming with normal blood pressure with a tachycardia, there may be some there are enough indications for a tachycardia, but in a trauma victim, if you see somebody with a tachycardia and evidence of bleeding, so it's about 30% blood has lost, like 1/3 of blood is lost. So you need to assess these patients and have to keep in mind that the patient might need blood. So delaying blood administration can increase the mortality. And so in class 2, so you will see a tachycardia, but the blood pressure may be normal, but there may be high diastolic pressure causing low pulse pressure. And in class 3, this is the these are the commonest presentations we see most of the time, because we have some delay in presentations where major trauma victims are coming with tachycardia and low blood pressure. So approximately they have lost about 40% of blood and they need blood. So if a trauma victim coming and if there are signs of blood loss, and if we'll say like in a point of care ultrasound says there are free fluid, and if the patient is having tachycardia and low blood pressure, that patient need blood. So you need to get a wide bore cannula to the cubital fossa. You need 3 investigations at the time of insertion of the cannula at least. That is, you need the hemoglobin level, you need the blood gas analysis, and you need DT and cross match. And so once you take the blood, so you inform the blood bank, you might need an uncross match blood for the victim. And the class 4 is the terminal stage where there is more than 40% blood loss and the heart rate is extremely high, and also sometimes you will see a bradycardia as a reflex. And so these patients need a massive transfusion, but most of the time the resuscitation may not be successful. So these are estimated amount of blood losses. The pelvic fractures, if there's a pelvic fracture, you can have at least about 2.5 liters blood loss. Femurs about 1.5 blood liters, and tibia fibulas altogether they can have about 1 liter blood loss. And the humerus, other things are minimal blood losses. So if you suspect a pelvic fractures, make sure you will reserve blood because patient might need blood. Right. So as I said, so you have to have a 2 large bore cannula, and you need to resuscitate fluid. So how do we resuscitate? So you need to resuscitate initially, because on admission there are no blood available, however much you need. So you might need at least 5 to 10 minutes to get the blood from the blood bank. So you start warm isotonic fluid. So the fluid you will give one, the maximum amount will be 1 liter for adult. So after 1 liter, the next step will be blood and blood products. So early use of blood and blood products are indicated, and it has shown that early usage of blood and blood products will be advantage in survival of the patient. And also it will be important in preventing coagulopathy and thrombocytopenia. And also failure to respond to the crystalloid and blood in initial stages, which might need immediate definitive interventions. So if a patient has received a normal saline 1 liter and ongoing blood does not pick up the blood pressure adequately, might need definitive interventions to stop the hemorrhage or stop the bleeding. Right, few words about damage control resuscitation. where there are some aspects. One is hypotensive resuscitation, that is to maintain the perfusion to vital organs with less risk of bleeding, because we don't keep the normal blood pressure in these patients, because if you pop the clot, so there will be bleeding continuously. So you need to have reduced blood pressure comparing with the normal blood pressure in these patients. So we call it hypotensive resuscitation. Usually our targets will be systolic 80 to 90. And you need to have hemostatic resuscitation. That means you need to give early blood and blood products in these patients. So as I said earlier, your maximum crystalloid will be 1 liter, followed by blood and blood products. And after the resuscitation, so as I said, like, you can't keep hypotensive resuscitation for so long. So because there may be problem with perfusion of the other organs as well. So once the resuscitation is completed, so you need to go for a damage control surgeries. The damage control surgeries are brief surgeries where they are more concerned about controlling the hemorrhage and spillage control. And so they should be completed within 60 to 90 minutes. So they are brief surgeries, and they do not intend to correct everything anatomically. They might go with stomas, and they will get the patient quickly to the ICU for resuscitation further. And then they will go for definitive surgeries later on once the patient has reserves. So this is important, and of course certain units are practicing, some countries are practicing damage control resuscitations in trauma victims. And we will talk few things about the coagulopathy that is very common very common occurrence in severe trauma. So if a patient is having already on anticoagulation, we need to reverse the anticoagulation. And the coagulopathy can happen due to various reasons, like starting with blood and blood products. So you can have dilutional coagulopathies, and acidosis, hypothermia, everything can contribute to the trauma coagulopathy. And there's another entity that is trauma-induced coagulopathy. Again, that is mediated by cytokines and not related to any of the other things mentioned earlier. So to tackle the coagulopathy, you need to administer blood with blood products. Usual thing is we tend to do the 1:1 basis, where packed cells to FFP, and then interchangeably platelets and cryo. TEG and TEM, or point of care testing, is important in some aspects where you can give required amount of blood and blood products, and should thereby you are not overloading the patient, and with that you might reduce some complications as well. And the role of calcium is debatable. Again, if the patient has evidence of low calcium levels, you can give calcium, but with the normal calcium level, no special benefits has been seen. So as I said earlier, hypothermia can contribute to the coagulopathy. So make sure you will give warm fluids, and if the patient's temperature is low, you need to get the measures to improve the temperature by other means. The role of tranexamic acid. So it has been proven with the trials like CRASH 2 and CRASH 3. Introduction of tranexamic acid within 3 hours of the injury is beneficial. So you will give 1 gram of tranexamic acid over 10 minutes, and also followed by a bolus, again 1 gram over 8 hours. So there are evidence that it will be beneficial in patients with multi-trauma and head trauma as well. Tranexamic acid will be beneficial for patient care, survival. So when it goes to the brief neurology or disability assessment, so you do a brief neurological examination, level of consciousness or GCS, and pupillary size and reactivity, and also do not forget blood sugar levels in your assessment. So everyone knows GCS, like the lowest score is 3 and the maximum is 15. The head injuries are classified according to the GCS. Up to 13, that is mild head injury, 12 to 9 moderate, and less than 8 is regarded as severe head injury. And when you completed the brief neurology, so you will go along with the exposure. So you need to expose the patient. And if the patient is, if the temperature is low, hypothermic, you might need some warm blankets, external warming methods to prevent hypothermia. As I said, it can contribute to coagulopathy, acidosis, and it will have adversely affect the patient's survival. So if the patient is stable, so you will complete the primary survey with log roll and inspect the back. So log rolling and inspecting the back is one of the important things we might miss, important things we have to do in emergency department or in primary assessment, because there may be some injuries we might miss if we don't do the log rolling. But the only problem is sometimes if the patient is already unstable, we might not be able to handle the patient for log rolling. And there are methods of doing log rolling. 4% or 5% log rolling can be advocated, but recent ATLS shows it's 4% log roll. That's why I have taken this image from the ATLS. So you need to inspect the back, look for any deformities stepping up and down, and then later finally you have to do a PR to see what is the rectal tone is like. So once you complete the primary survey, if the patient is unstable and you have given blood, everything, so if there are signs of bleeding, and if you think patient might need some interventions, the patient might go to theater. If a patient is stable, the patient might go along with the secondary survey from head to toe, thorough examination. And there are some important adjuncts to the primary survey where it will be beneficial for us to come to diagnosis. For example, for ECGs, pulse oximetry, capnography, and blood gas. So we will be talking about the blood gas in another 15-20 minutes time as well. And some other urinary and gastric catheters for the indications, and FAST for the focal assessment of sonography in trauma. And of course, we don't see much of a diagnostic peritoneal lavages now. And also if there are mobile x-rays. So these things are adjuncts to the primary survey, which will be important to come for us to come to some of the diagnosis for us to treat this patient. So I will be talking very few things about FAST, because this is very commonly used one. So everyone in working in emergency departments or in critical care settings are using FAST scans, using ultrasounds to do FAST scans. So there are 4 views, as everyone knows. So goal is to evaluate for free fluid, not to do any other hi-fi things in ultrasound, but just to see whether there are free fluid in any of the 4 windows we see. And also the other important aspect is we can identify cardiac tamponade, and also if we can go if we can find the hemothorax, one of the benefits of the ultrasound as well. And this is how we diagnose pneumothorax using point of care ultrasound. So there are two signs where, like, if you see a barcode sign, you can think of it, it can be a pneumothorax. And also if you see a seashore, that is the normal ultrasonic appearance without a pneumothorax. So the ultrasound in chest is specific and sensitive, equal to chest x-rays, more than that as well. And so once the patient is complete, once you complete the primary survey, the patient will go along with the secondary survey. So one of the doctors will assess him detailed. So you will get a ample history, that is a brief history with regard to allergies, medications, past medical history, last meal, and events followed by. So you might get some information from the bystanders or relatives, and then you do the physical examination from head to toe, and then so you will again reassess this patient with regard to whether there's any deterioration of the vitals. And then if the patient is stable, patient will go for a diagnostic studies. For example, the patient might go to a radiology department for a CT or other chest X, trauma series chest X-rays. So there are some signs of head injuries. So you might elicit in your secondary survey, like raccoon eyes, battle sign, and hemotymphanogram. And also in the abdomen and chest, you might see sometimes a seat belt sign, where you might think of intra-abdominal injuries in this situation. So diagnostic aids include radiology and blood analysis as well. So you will do a standard trauma bloods, like full count, electrolytes, ethanol levels, blood, and coagulation profile as well. And also the trauma radiographs include chest x-ray, pelvis, and of course the cervical spine will be included in a CT most of the time to exclude cervical spine injuries. And as I said, so once the patient is stable, patient can go to a radiology for CT scans. And when the patient is in radiology, because it might take some time, patient should be monitored. And also the other important thing, unstable patients should not in a radiology unit. So if you stabilize a patient can go to a radiology, because there are some adverse things can happen, because the radiology set of x-rays and CTs might take at least 30-40 minutes. Patients without a monitor, unstable patient goes, the results will be disastrous. So this is a picture showing a pelvic fracture. So if you see a pelvic fracture in a patient, the trauma victim, you know that these are unstable fractures. You might need some measurements like pelvic binders and early blood and blood products, and orthopedic team involvement for later definitive care. And this is a CT showing EDH with a midline shift and a cerebral edema. So this kind of patient, depending on the GCS level, you might need intubation, and also you might need some measure to reduce the intracerebral pressure, 3% saline, starting of 3% saline, and if the patient is intubated, you might need neuroprotective strategies to reduce the ICP. So this again picture of STH. So it shows like there's a evidence of brain honing, so you need intubation and neuroprotective strategies before surgical intervention. Right. So once you diagnose all these conditions in a trauma victim, it's important for us to think about the disposition. So as I said earlier, the patient disposition, like if the patient is unstable who need a definitive care, the patient might go to a theater directly from emergency department. And sometimes unstable, so once you resuscitated, if there is no acute surgical interventions needed, the patient can go to a HDU ICU facility and then resuscitated further. So the other important thing for us is if we need to transfer this patient from our hospital to another facility, we should coordinate the efforts because it's very important. It will reduce the delay in a the referral center, because we have seen a lot of transfers where they do the very critically ill patients are transferred without coordination, and we had adverse effects on the way to the hospital. And also once the patient received to the hospital, if the receiving end does not know, if the receiving does not have the facilities, it should be a disaster for a patient, and all the efforts done by the previous team will go in vain. So make sure when you are transferring a patient to a referral center, coordinate before transferring. So you need, again, the other important thing is if you are transferring, please stabilize a patient before transfer, because we have seen some patients are transferred just like, as I said earlier, like if you see some injury, you transfer this patient, or you need a head CT, but the patient can die with a abdominal bleeding. Right. In summary, so what I wanted to highlight is the trauma is best managed by a team approach, and so the teamwork will have a good outcome in trauma management. And also once the patient received a thorough primary survey and secondary survey is to key to identify life-threatening injuries, and also might need to treat them then and there. So once a life-threatening injury is discovered, intervention should not be delayed, and you should not wait for a history or definitive diagnosis. And the disposition is determined by the patient's condition as well as the available resources. So I think this is what I'm going to do with regard to management of major trauma victim. So I didn't focus on specialty things. I just wanted to go through a general approach of a trauma victim and what to do in emergency department, and highlighting few key aspects of things we might miss in our management. Thank you very much.